I'm Joanne Mitchell, but I'm known as Jo to everybody here. I am a therapeutic radiographer, or an RTT, working at the Edinburgh Cancer Centre. My role now is the principal research radiographer, and I have a responsibility to manage our radiotherapy clinical trials team, the radiographers in that team, and also to do my own research and also facilitate others to do their research too. In Edinburgh, we have decided to make this an RTT-led procedure, which it's great for time efficiency because it's as a fellow RTT, it's something that you can then have more control over, and sort of make sure you can get the right people in the right place to do the tasks that are needed to do. It's allowed my colleagues to develop skills in catheterisation. But I do think the biggest thing is the difference that it has made to the clinical on-treatment workflow itself, and it's given us more information to make more, I'm not sure direct is quite the right word, but more informed treatment decisions at time when we are delivering the radiotherapy treatment. It's made us probably question our decisions a little bit more, and it's allowed us to make those decisions more independently because of the knowledge and the information that RayPilot brings to us at that point in time. We do work as part of a multidisciplinary team. We're not making these decisions completely on our own. We're taking everybody's input into these decisions. But actually, when the patient is present in the department and on the bed having their treatment delivered, we can make those decisions because you have the information to hand, with basically how the prostate is moving and potentially what that is going to do to the organs at risk. It's very much being able to correlate the motion that we're seeing at time of treatment delivery, that having that in real time, it's made us question the difference of what does happen when the patient is lying on the bed, because to deliver the treatment, there's motion happening all the time. You can't take away motion no matter what you do prior to the patient coming in, no matter what information you give to the patient. If you have a living, breathing patient on the bed, you have motion. We question more, I think, what then that motion can do. So it really has informed us more when we're delivering the treatment about the decisions that we're making at that point in time. It makes us think more about our role in the adaptive cycle. We can adapt our treatment plans, we can have plan of the day, we can look at which is the best plan to deliver. But at that moment when we are switching the treatment on, it's an RTT who is responsible for that treatment and making sure that that treatment is delivered accurately. And I think having that knowledge and being able to do that on a linear accelerator has been fantastic to us as a profession, as a community. The big thing that we've got is the precision study, which is the 3-fraction study. And that hopefully will be adopted throughout Scotland. So that's going to be very, very exciting to share our knowledge, to have a bigger database also of patients that we can look at. But also from the RTT perspective, using the HyperCath device, with the device now being placed as a urinary catheter, it's allowed us as RTTs, we can see the urethra as an organ at risk. That there's literature out there that does state that there's a potential correlation, a direct correlation between the dose that the urethra receives and a GU toxicity that the patients do experience. But when we've delivered our treatment using a linear accelerator and we take a cone beam CT, you can't see the urethra. It's never been a structure that we have probably had to really take into consideration. So for us, as a team, as an RTT team, we're looking to see how we can match our patients to the urethra, so actually really know what dose we're delivering to the urethra. That'll be matched more accurately to the plan that we've created at the beginning. We can then also measure the dose that that structure has received and hopefully correlate that to outcomes. And then we can maybe compare with patients who we've not been able to do that, if there is any difference with what our patients are actually experiencing. What has been very, very comforting is the number of patients who are coming back after just a few weeks and they're not really reporting any toxicity, because that's obviously the gold standard that we want to get to. We don't want patients to have any form of toxicity after having this type of treatment. The patients that we are looking after are hopefully going to live for a long time, and it's not now just about let's cure these patients. It's actually about what cost or is this cure, and we really want to leave people where the quality of life is as good as it was before they started with any symptoms, or having to go to the doctor thinking that they were maybe they did have sort of prostate cancer. Everybody has spoken very favourably about being able to sort of have the treatment in 5 fractions and have the hypercath device inserted. Obviously, the PACE study has published, which is indicating that hyperfractionated radiotherapy is the way to go, which is fantastic. It's fantastic for us in the department as a workflow, but also for the patient. That is absolutely fantastic that we can deliver this treatment in 5 fractions. Our own personal experience, as I think I previously mentioned, is side effects are more than tolerable. We're seeing late, sort of no real toxicity reported in our patients who are now under our late follow-up. Acute side effects have diminished, which is fantastic. We obviously don't know yet what the 3 fraction regime will give us, but I'll be very hopeful that we can achieve the same. If we can achieve the same treatment delivery, that we can achieve the same outcomes in those patients, which again will be very, very favourable for those patients. I do think obviously the 5 fraction will be adopted as standard of care. So in adopting that regime, you've then got to look at how you are going to deliver that treatment. Your margins become more important, the motion becomes more important, so there's more questions comes into your treatment decisions in being able to do that. So all of these things for an RTT, there's more decisions that we need to be making. We need to be more accurate when we are delivering our radiotherapy treatment. The other thing that I didn't mention previously with using hypercath is we can really direct the dose away from the urethra if we need to, which is something that delivering your treatment on a linear accelerator we've not been able to do previously. The urethra has not been thought about maybe in the RTT community as an organ at risk because we've not been able to see it on our images. So it's going to be very, very interesting to get that information in the time, as we sort of progress with our work with RayPilot and hypercath, and to be able to actually look at that organ as an organ at risk and see what difference that can make to the patient. So I definitely think 5 fractions will be adopted as standard of care, but also I'd like to see that we do keep pushing the boundaries with prostate cancer treatment delivery, because I do think we've got the ability to, and we know that the prostate gland can withstand quite high radiotherapy doses, and to be able to deliver that dose to just the prostate gland and really minimise that to the organs at risk, which are now the bladder, the rectum and the urethra, then that could potentially make quite a difference to the patients. I think it's the role of an RTT in something like this. You've got to remember what we can bring to the table in our skill set, and being involved with this device, this study that we've had ongoing now for a number of years. It's really shown what we can bring as a team, and also how we can impact patients and their overall outcomes